Non-fasting lipid panel for dyslipidemia screening, evidence, guidelines, and clinical management. Dyslipidemia affects is almost equal to 34% of U.S. adults and contributes to is almost equal to 1.9 million cardiovascular deaths worldwide each year. Non-fasting lipid testing, validated in greater than or equal to 95% of patients with triglycerides less than 400 mg per deciliter, simplifies screening without compromising risk stratification. The 2022 ACC/AHA and 2022 ESC/EAS guidelines endorse a non-fasting total cholesterol, HDL C, and calculated LDL C as the primary laboratory strategy for adults greater than or equal to 20 years. First-line therapy with high-intensity statins, e.g., atorvastatin 80 mg daily, reduces 10-year ASCVD events by is almost equal to 30%, NNT is almost equal to 30, and remains the cornerstone of management. Key points. Note, non-fasting total cholesterol, TC, greater than or equal to 200 mg per deciliter, LDL C greater than or equal to 130 mg per deciliter, or triglycerides, TG, greater than or equal to 150 mg per deciliter identifies is almost equal to 70% of individuals who meet guideline-based treatment thresholds. The Friede-Wald equation remains accurate for LDL C calculation when TG less than 400 mg per deciliter, with a mean absolute error of plus or minus 5 mg per deciliter compared with direct measurement. ACC/AHA 2022 recommends universal lipid screening at age 2035 years, greater than or equal to 20Y, and repeat every 5 years, for ages 3545 years. Repeat every 3 years if TC greater than or equal to 200 mg per deciliter. ESC/EAS 2022 advises a one-time non-fasting lipid panel at age 18 years, then every 5 years for low-risk individuals, 10-year ASCVD risk less than 5%. High-intensity statin therapy, atorvastatin 80 mg PO daily or rosuvastatin 2040 mg PO daily, lowers LDL C by is almost equal to 50% and reduces major adverse cardiovascular events, MACE, by 30%, HR 0.70, 95% CI 0.620.78. PCSK9 inhibitors, alirocumab 75 mg SCQ2W or evolocumab 140 mg SCQ2W, achieve an additional is almost equal to 60% LDL C reduction on top of maximally tolerated statins, with a 15% relative risk reduction in MACE, Odyssey outcomes, NNT is almost equal to 44/5Y. Ezetimibe 10 mg PO daily added to statin therapy yields a further is almost equal to 20% LDL C reduction and a 6% absolute risk reduction in composite cardiovascular outcomes, improve IT. NNT is almost equal to 50/7Y. Lifestyle modification targeting a 5% weight loss, less than or equal to 2,000 kilocalories per day, less than or equal to 150 minutes per week of moderate intensity aerobic activity, and saturated fat less than 7% of total calories reduces LDL C by is almost equal to 10 mg per deciliter on average. In patients with chronic kidney disease stage 3, eGFR 3059 ml/min/1.73 square meter, statin dose reduction to 1/2 the standard, e.g., atorvastatin 20 mg, maintains greater than or equal to 30% LDL C lowering while minimizing myopathy risk, is almost equal to 1.2% versus 2.5% in full dose. Pregnancy-compatible lipid management limits statins to prevastatin 1020 mg PO daily, Category B, after the first trimester, bile acid sequestrants, cholestyramine 4G PO daily, are safe throughout gestation. Non-fasting. Overview and epidemiology. Dyslipidemia, defined by abnormal concentrations of plasma lipoproteins, is coded under ICD-10E78.0E78.5. Globally, is almost equal to 1.3 billion adults, is almost equal to 31% of the world population, have elevated LDL C greater than or equal to 130 mg per deciliter, with the highest prevalence in North America, 34% of adults, and the lowest in Sub-Saharan Africa, 12%. In the United States, the National Health and Nutrition Examination Survey, NANS, 2017-2020 reported that 34.2% of adults greater than or equal to 20Y have LDL C greater than or equal to 130 mg per deciliter. 28.5% have TG greater than or equal to 150 mg per deciliter, and 22.1% have HDL C less than 40 mg per deciliter, men, or less than 50 mg per deciliter, women. Age-specific incidence rises sharply after 30Y, reaching 48% in the 4564Y cohort and 62% in those greater than or equal to 65Y. Sex differences are modest. Male is almost equal to 36% versus female is almost equal to 33% prevalence. But women experience a 1.3-fold higher relative risk of ASCVD when LDL C exceeds 190 mg per deciliter after menopause. Racial disparities are notable. African American adults have a 1.4-fold higher prevalence of low HDL C, while South Asian immigrants exhibit a 1.6-fold higher prevalence of elevated TG. Key points: dietary saturated fat greater than 7% of total calories, RR 1.30 for ASCVD. Physical inactivity less than 150 minutes per week of moderate exercise, RR 1.25. Obesity, BMI greater than or equal to 30 kg per square meter, RR 1.45. Smoking, current, RR 2.0. Pathophysiology. The central pathogenic event in dyslipidemia is the excess delivery of ApoB-containing lipoproteins, VLDL, IDL, LDL, to the arterial intima, initiating atherogenesis. LDL C particles bind arterial proteoglycans via positively charged lysine residues on ApoB100, facilitating subendothelial retention. Oxidative modification of retained LDL, OXLDL, triggers macrophage scavenger receptor, SRA, CD36, uptake, forming foam cells that constitute the fatty streak. Genetically, loss-of-function mutations in LDLR, heterozygous familial hypercholesterolemia, FH, reduce hepatic LDL clearance by is almost equal to 50%, raising plasma LDL C by is almost equal to 100 mg per deciliter. Gain-of-function PCSK9 variants increase LDLR degradation, elevating LDL C by is almost equal to 30 mg per deciliter per allele. Polygenic risk scores incorporating greater than 200 SNPs predict a two-fold higher lifetime ASCVD risk when the top 5% of the distribution is considered. Clinical presentation. Dyslipidemia is largely asymptomatic, is almost equal to 85% of patients are identified through screening rather than clinical signs. When present, classic manifestations include, atypical presentations are more common in elderly, greater than 65Y, and diabetic cohorts, where is almost equal to 30% exhibit isolated low HDL C without overt LDL elevation. In immunocompromised patients, e.g., HIV on protease inhibitors, drug-induced hypertriglyceridemia, greater than 500 mg per deciliter, occurs and is almost equal to 22% and may precipitate pancreatitis. Key points: tendinous xanthomas, found in is almost equal to 12% of heterozygous FH patients. Corneal arcus before age 40, is almost equal to 18% prevalence in FH. Lipemia retinalis, rare, is almost equal to 2% of severe hypertriglyceridemia greater than 1,000 mg per deciliter. Tendon xanthomas, sensitivity is almost equal to 15%, specificity is almost equal to 99%. Diagnosis. 1. Initial non-fasting lipid panel, TC, HDL C, TG. If TG less than 400 mg per deciliter, calculate LDL C using Friedewald, LDL C equals TC minus HDL C minus TG/5. For TG greater than or equal to 400 mg per deciliter, obtain a direct LDL C assay or repeat test after a 12-hour fast. 2. Risk stratification using the 2022 ACC/AHA ASCVD risk estimator, 10-year risk. Thresholds, greater than or equal to 7.5%, moderate to high risk, greater than or equal to 20%, high risk. 3. Secondary causes, order thyroid panel, TSH, free T4, fasting glucose/HbA1c, liver panel, ALT, AST, renal panel, creatinine, EGFR, and assess for medication-induced dyslipidemia, e.g., glucocorticoids, antiretrovirals. 4. Genetic testing for FH if LDL C greater than or equal to 190 mg per deciliter or family history of premature ASCVD. Cascade screening recommended for first-degree relatives. Test or reference range, sensitivity, specificity, total cholesterol, less than 200 mg per deciliter, 92%, for ASCVD risk greater than or equal to 7.5%, 78%. LDL C, calculated, less than 130 mg per deciliter, optimal less than 100 mg per deciliter, 88%, 81%. HDL C, greater than 40 mg per deciliter, men, greater than 50 mg per deciliter, women, 70%, 85%. Triglycerides, less than 150 mg per deciliter, 95%, for hypertriglyceridemia detection, 90%. Direct LDL C, if TG greater than or equal to 400, less than 130 mg per deciliter, 96%, 84%. Key points. Coronary artery calcium. CAC, scoring. A Gadsden score greater than or equal to 100 predicts ASCVD events with a hazard ratio of 2.5, 95% CI 2.03.0, in intermediate risk patients. Carotid intima media thickness, CIMT, an increase of greater than or equal to 0.1 mm per year correlates with a 1.3-fold higher risk of myocardial infarction. ASCVD 10-year risk. Points derived from age, sex, race, total cholesterol, HDL C, systolic BP, treatment for hypertension, diabetes, and smoking. A score greater than or equal to 7.5% triggers statin consideration. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.